Yeah, totally. That's fine.
All right, so it's 12:30, so it's time to get started. So thank you everyone for joining us today for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you all in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaging the session, keeping your cameras on when appropriate, registering for CME credit for each session, and completing and submitting a session eval form. The next slide, please. So the activity code for today is here. It's 100932236. To get your CME credit via text, just text your email address to the number and text attend in that number. So I'll leave this up here for a little bit so you can each get your CME credit. All right, next slide, please. And again, this is just more instructions about how to get your CME credit via text. All right, next slide, please. And then this is information on how to get your CME transcripts. Next slide, please. And then this is just information regarding the AAFP credit system. All right, next slide, please. And these are the FCM Grand Rounds core competencies that we address. All right, next slide, please. Sandhya, Kumar, and Andreas, Lazaris, they have no financial relationships with ineligible companies to disclose. All right, and Dr. Shi will present or introduce y'all.
It's my honor and privilege to introduce Dr. Kumar and Dr. Lazaris today to give us the grand rounds today. So Dr. Sandhya Kumar is Assistant Professor, Director of Homeless Healthcare Curriculum, and the Associate Program Director for the Family Medicine Residency at Montefiore and Einstein Department of Family and Social Medicine. So she has created and continues to direct the Homeless Healthcare Elective, the 2-year Homeless Healthcare track, as well as the NYC Homeless Healthcare Fellowship. So Dr. Kumar's clinical experience includes providing primary healthcare with the street outreach team and at domestic violence and family and adult shelters. And Dr. Lazaris is one of the current fellows on this fellowship program. I'm gonna let him introduce himself to the audience. Thank you.
Sure. Hi, I'm Dr. Lazaris. My first name is Andreas. I am one of 2 fellows in the New York City Homeless Healthcare Fellowship, and I'm family medicine trained. I graduated from the Mount Sinai residency at the Mount Sinai Hospital in New York City, and I have special training in HIV medicine as well.
All right, well, hello, and thank you so much for sharing your time with us today. We really appreciate being able to talk about this topic with you all. These are our objectives for this afternoon. At the end of the session, we hope that you will be able to describe the relationship between health and homelessness, describe clinical considerations for patients experiencing homelessness, and identify resources to refer patients to. For just a little bit more context, our program at Montefiore has had a really special legacy of graduating residents to work in homeless healthcare spaces for a long time. And over the past 8 years in our program, we've worked to develop a formalized homeless healthcare curriculum, recognizing that a lot of folks come to our program with that specific intent and hoping for additional exposure and training. So as mentioned, we have an elective experience, which has hosted residents in family medicine, IM, as well as OB. We have our 2-year homeless healthcare track, which is a longitudinal curriculum. These are 7 of our graduates from the track who are all working in homeless healthcare spaces right now. And in 2020, we launched a one-year fellowship, which has graduated 6 fellows. And this afternoon, I'll be delivering this lecture with one of our fellows, Andreas, and unfortunately, our other fellow, John, is not able to join us this afternoon because of patient care. So over this hour together, we will explore some of these concepts like affordable housing. We'll talk about how many of our neighbors are impacted by homelessness and how to support patients experiencing homelessness. And we'll talk about it in the context of a few brief cases. So I always like to start these conversations with this important quote from Dr. Stefan Cortez. Homelessness is a state, not a trait. Homelessness is not static. It can come and go. So it's important to ask about where a patient is in that moment. And in thinking of homelessness as a state and not a trait, we also encourage using people first language, which emphasizes that people experiencing homelessness are first and foremost people. So over this hour, you will hear us saying that a person is unhoused, or that a person or people are experiencing homelessness, or a person or people are undomiciled, or do not have a home right now. And in the epic EMR world in which we all live, for the same ICD code, you can enter a social diagnosis of lives in homeless shelter or lack of housing instead of a homeless single person or homeless family, again, re-emphasizing that homelessness is a state, not a trait. So how many people are experiencing homelessness in the US? On a single night in 2023, roughly 650,000 people were experiencing homelessness across the US, with almost 30% experiencing homelessness as part of a family with children. Homelessness is incredibly common, and all of us are going to be caring for people experiencing homelessness. And our goals are really to provide the highest quality of care for our most marginalized neighbors. It's important to note that Black Americans have remained considerably overrepresented among people experiencing homelessness due to many policies that historically excluded Black Americans from accessing opportunities for housing and establishing generational wealth, in addition to the various and numerous societal structures that maintain racial inequality. Black Americans account for 37% of people experiencing homelessness and half of people experiencing homelessness in families, despite only being 13% of the US population. So what is the relationship between health and housing? I think this is pretty intuitive for most of us. Some health problems precede and causally contribute to homelessness. Others are consequences of homelessness, and homelessness complicates the treatment of many illnesses. Depending on what device you're on, this might be too small, but I really appreciate this figure, which describes the upstream systemic barriers and burdens like poverty, trauma, victimization, social exclusion that contribute to downstream medical causes of high morbidity and mortality of people experiencing homelessness, such as heart disease, infectious diseases, mental illness, and substance use. And in turn, downstream causes magnify the negative effects of and when about people experiencing homelessness, it must address intersecting health and social burdens by combining health-related and social interventions. Almost all medical conditions are seen in higher rates among people experiencing homelessness. And an important point that I hope that you take is people with chronic experiences of homelessness have higher rates of illness and die on average 12 years sooner than the general US population. And incredibly devastating, this does not correct to baseline after someone is housed. The damage to health of experiencing homelessness. So I'm going to spend a minute discussing a model of healthcare delivery tailored for this population. Tailored homeless healthcare programs organize services specific to the health needs of patients experiencing homelessness and have very tight interdisciplinary teams of medical providers, mental health services, and social service providers. And these tailored homeless healthcare programs have shown to increase continuity of primary care services, reduce hospitalizations and non-emergent ED use, produce cost savings to the system, and very importantly, are well received by our patients. So these are some of our past fellows at their tailored homeless healthcare organizations. So they are meeting patients physically where they are. So here is Christelle. Christelle is in a clinic embedded within a shelter for women with serious mental illness and complex chronic conditions. This is Irfan. He is with a street medicine team in this picture. And Stephanie is in front of a mobile unit with her healthcare team. So this is what a typical mobile unit looks like. It has a small space for patients to register. There is space for labs and immunizations to be administered. There's oftentimes a small consultation room, which sometimes has a mini exam table. And there's a larger clinic room. And when I've worked in mobile units in the past, I've been able to do most things I could do in a standard clinic, including PAPs and Nexplanons and joint injections. So when we talk about tailored homeless healthcare, it is this special model of healthcare delivery, but it also shares this philosophy of recognizing that the patient is the expert in their own lives, that we measure success as guided by patient values, and we prioritize the maintenance of safety and dignity and avoidance of re-traumatization for all of our patients in all interactions. So we'll talk about definitions of homelessness. So these are definitions used at a federal level and defined by HUD, which also provides guidance for all homeless services across the country. So someone is defined as experiencing homelessness and therefore eligible for certain services if they fall into one of these four categories. Literally homeless, meaning they lack a fixed, regular, and adequate nighttime residence. The second category is if they are at imminent risk of homelessness. The third category is if they are homeless under other federal statutes, such as precariously housed individuals. And the fourth category is fleeing or attempting to flee domestic violence. It is important to note that this excludes a lot of people, including those who are living doubled up or couch surfing and not just to save money. Health and Human Services and the U.S. Department of Education both have more inclusive definitions that include people who are residing doubled up. And you will see that reflected in their much higher estimates of people experiencing homelessness. The primary causes of homelessness, particularly among families, is a lack of affordable housing, with major immediate triggering causes of homelessness, including eviction, leaving a severely overcrowded housing, domestic violence, job loss, and hazardous housing conditions. So what is considered affordable? Spending 30% or less of pre-tax income towards rent would qualify that housing as affordable. Here in New York City, over 40% of our neighbors are rent burdened, and over 20% are severely rent burdened, meaning they spend over 50% of their pre-tax income on rent. It's important to also take a step back and acknowledge housing affordability is a joint function of incomes and the cost of housing. So incomes that are below levels that cover basic needs put even the lowest cost housing out of reach for many. So once someone does lose their home, where they experience homelessness impacts their morbidity and mortality. So a cohort study published in 2018 followed 445 unsheltered adults and found that all-cause mortality rate was almost threefold larger than those who were sleeping in shelters and nearly 10-fold larger than those in the general population. So how can we support our patients experiencing homelessness? So first, I would say harm reduction. So many people think of harm reduction with regard to resources for safer consumption of substances, but we work to apply principles of harm reduction to all aspects of our healthcare delivery. It's about working within the reality of our patients' lives and focusing on our patients' goals and figuring out how can we as physicians help support our patients to meet these. So there's a lot of text on this slide, but these are 3 suggestions for how to support patients experiencing homelessness. And this comes from Dr. Stefan Cortez, who I had mentioned earlier. So first, ask patients in specific terms how they're living and where they're going. Experiences of homelessness can mean a lot of different things. It could mean that a patient is staying under an overpass, or it could mean that they've been staying at a shelter with their family with regular access to a kitchen or meals or bathroom. So ask patients where they're living and where they're going. Second, tailor your care to your patients. Discuss the gold standard as you would for a loved one and ask if they think it would work. They will tell you if they don't think it will work, and then you can work from there. Third, many patients have a history of being treated poorly by the medical system. So being mindful of that and knowing that trust is something to be earned over time. And one very simple way to support patients is to simply involve them in any communication with other providers. So making the phone calls or writing letters or the epic staff messages with your patient right beside you. So we're going to apply some of these principles as we transition to talking through a few cases. So starting with Mr. K. Mr. K is a 46-year-old cis male presenting to clinic to establish care. He has a history of a serious mental illness, was hit with a metal pipe when he was 17 years old, which resulted in a chronic TBI and right vision loss. He also has hypertension. He has had numerous reconstructive surgeries related to the traumatic injury. As far as medications, he's only on lithium, and he does say that he was on lisinopril at one time for blood pressure, but he was taken off in the emergency department after he had facial swelling. So we asked Mr. K where he's been staying the last few nights. And he shares that he's been at the JAMS shelter, which is a transitional shelter that he's been staying at for the past 12 months. It is a single adult shelter that is a dorm-style congregate living with 20 other adults in a room. He has a case manager there who is primarily focused on supporting him on his application to get into permanent supportive housing. He does get all of his meals at the JAM shelter, and he's able to return to the same bed nightly. But if he's away from the bed for a night or two, he risks losing his bed and his belongings. So when exploring what brings him in, he describes that his friend just died, and he wants to get checked out and wants to be healthy. When exploring his goals, he shares that he wants to live in his own apartment in the Bronx because he has family in the area. And we explore who is Mr. K's support system. He mentioned family in the area. Are there friends in the area? He has a case manager at the shelter. Does he want them to be involved in also supporting around healthcare coordination? Mr. K has a history of serious mental illness. Does he have an ACT team? Who is prescribing him his lithium? Who is his psychiatrist? Do they have other care team members like a case manager or harm reduction specialist? So Mr. K is on lithium. He might be getting labs somewhere, and he also has been in a hospital at some time. So can we get records? When we get to the physical exam, it's notable for an elevated blood pressure. He's unable to open his right eye. He has healed scars along his cheek and nasal bridge. He has a mildly flat affect and makes good eye contact. The rest of the exam is unremarkable. So what do we offer Mr. K? So there is a Healthcare for the Homeless Preventive Medicine Task Force, just like USPSTF, that offers guidance regarding healthcare screenings and immunizations, which over time, as we get to know Mr. K, we can offer these. Mr. K today declines blood draw, but still wants to get checked out. So what labs can we still offer him today? We can still offer point of care testing if we have it on site, so hemoglobin A1C, HIV test. We can also offer urine microalbumin, urine gonorrhea, chlamydia, when appropriate, and discussing the limitations of these tests. For consideration for hypertension management. So I review 4 questions when thinking about hypertension management. Does this patient have stable shelter? And are they primarily indoors? And what I'm trying to assess is risk of dehydration. Are they able to attend regular clinical encounters? Are they willing to have blood draws? And are they not on psychiatric medications prone to cause dehydration? If the answer is yes to all of these, then can consider an ACE or an ARB, thiazide, or calcium channel blocker. And if the answer is no to any of these, then I offer a calcium channel blocker and I explain why. We don't know if Mr. K has diabetes at this point, but I just want to bring up this issue of insulin treatment among people experiencing homelessness. I've seen providers not even offer insulin treatment for patients who would be appropriate for because of assumptions about ability to take or to store medicine. So yes, we should absolutely be exploring with a patient about food insecurity and refrigeration and storage. At the same time, we can counsel around their particular situation. If patients are street domiciled and keep their insulin in their backpack, recommend to store the insulin in the part of the backpack not facing the sun. Aim to use basal dosing as much as possible. And when food access is an issue, discuss running a higher A1C goal to avoid the risk of hypoglycemia. And when their circumstances change, reassess the A1C goal. Also, many insulin products are stable at room temperature. UCSF has an online guide with recommendations for insulin storage at room temp, and you'll see that a number are stable for 4 weeks. This is an example of why it's so important to offer the gold standard, ask the patient what they think of the treatment, and tailor your care to the patient. For concrete services, I encourage connecting patients with clinic-based community health workers or social workers. And at point of care, one resource for food security that I think is very helpful is Hunger Free America, which runs the USDA Hunger Hotline, and it connects individuals to immediate food access like food pantries and soup kitchens. And they also offer support for individuals applying for long-term food support. So on their website, you can enter an address, select what services you are seeking in that area, and it will provide a list of local services. Okay, so we're going to go ahead and move on to our next case, which Andreas will review.
Okay, so I actually gave a little bit of this information in my intro. So we can scoot to the bottom portion, which basically states that as part of the fellowship, I am also working with an organization called Janian Medical Care, which is an organization that's contracted to work in some of the settings that Dr. Kumar had mentioned. So I'm actually in my office in a supportive housing site called the Sands, where I am every Monday and Wednesday. And then on Tuesdays, I'm at a Safe Haven clinic, which is called the Baxter in East Elmhurst, Queens. And so I'll talk a little bit more about those specific settings on the next slide. So where I'm currently situated is in the bottom floor of the building on your left side of the screen, which is called the Sands. It's a permanent supportive housing site where folks who were formerly experiencing homelessness are now permanently housed in their own apartments. There are 491 residents total, 305 of whom were formerly experiencing homelessness and have kind of had different touch points with a lot of the places that we've talked about, street-based settings, shelters, safe havens. And that is where I am today. The Baxter is the building on the right. It's the kind of the smaller, shorter building on the right, which is a safe haven of 74 residents. It is typically a transitional housing space where folks, many of whom are coming directly from street homelessness, and typically share a room with 3 other residents and are at some point on the trajectory toward permanent housing. There are a considerable number of folks who live in the safe haven who are undocumented and who do stay in the safe haven for longer periods while they find alternative means of housing. Next slide, please. So this case actually takes place at the Sands and involves a 47-year-old patient who has a past medical history primarily of opioid use disorder, uses fentanyl, which is injected intravenously, and uses what she says is 1/4 gram a day, which equates to about 2 to 3 bags. And just as far as some verbiage is concerned, 1 gram equals to about what's called a bundle, which is about 10 bags. And so various individuals will kind of refer to use in a variety, in one of these types of ways. So it's helpful to know a little bit of kind of how that metric is used. This patient also uses benzodiazepines, both prescribed and street purchased Xanax, up to 9 milligrams in 1 day. And she also has co-occurring major depressive disorder, generalized anxiety, and panic disorders. So she presents as a walk-in to the supportive housing-based clinic, and she was brought by her case manager after she declined emergency department evaluation. So this patient I actually met on my first ever day in clinic, and I'm still working with her. So next slide. So the way that this patient presented was she had leg wounds that were present on her distal right and left lower extremities for about 2 weeks. They appeared within 1 to 2 days of injecting fentanyl. The left leg was very painful, red, swollen, and she received a 10-day course of amoxicillin from an outside PCP that she had completed 2 days prior to evaluation. She reported weeping from and black film in all of the wounds. She doesn't have any known history of peripheral vascular disease or venous insufficiency, and reports that this happened one other time, but the wounds were a bit more proximal. Next slide. Her physical exam, vitals were largely within normal limits, afebrile, normotensive with a normal heart rate and normal oxygen levels. Her left lower extremity had 2 6-centimeter, well-circumscribed, oval-shaped lesions on her shin, which both had a black eschar, a large area of redness surrounding both of the lesions with warmth and tenderness. The most distal lesion was weeping, though it was not virulent. On the right, many more smaller, well-circumscribed lesions without a black eschar, some red streaks on the medial portion of the shin that extended downwards toward the ankle. The pulses in the distal lower extremities were intact, and sensation to light touch was intact. Next slide, please. So these are not exactly the wounds, but these are samples of similar wounds. And you can see many of these have this black eschar, some surrounding erythema, and can be found oftentimes in the distal extremities, distal arms, distal legs, especially in these photos. Next slide. So the suspected source is something called xylazine, which will kind of be the main character of this portion of this presentation. Next slide, we'll talk a little bit more about it. So what is xylazine? Xylazine is a contaminant that is found in fentanyl, heroin, and cocaine. It primarily works as an alpha-2 adrenergic agonist, but it also has some opioid receptor agonist activity on the kappa opioid receptor. which is not many of us are familiar with. It is not FDA approved for humans. It's only FDA approved as an anesthetic and analgesic in animals. As a drug contaminant, it was first seen in Puerto Rico in the early 2000s. Sorry, just trying to make this function a little better. I think there's some delay with my internet function in the United States, and has now made its way further south and further west. Supplier that it may enhance euphoria and analgesia and may also reduce frequency of injections. Names that folks may hear it called by are trank dope, anestesia de caballo, which literally means the anesthesia for the horse, rampun or anesthetic. Next slide, please. So why is this something that is relevant to physicians, to patients? The reason is because there are multiple sequelae kind of across three dimensions that are noteworthy. One is a compounded risk for overdose death. So combining the respiratory depression risk of fentanyl and heroin, xylazine offers a CNS depressive risk and compounds the risk of overdose death. As we're discussing, wounds. These are typically severe necrotic skin ulcerations, which can appear both in people who do and do not inject. So people who use intranasally, people who smoke, and it can occur beyond sites of local injection in folks who do inject. The perceived mechanism is that it's a possible peripheral vasoconstriction from alpha-2 receptor activation, causing these superficial wounds that eventually become deep necrotic wounds. And then finally, limb risk, secondary to enhanced sedation. So a lot of times the sedation can actually last almost twice as long as it would without xylazine within the supply, which then puts folks at risk for clots, compartment syndrome, and rhabdomyolysis, depending on their positioning and their cutting off of blood supply to distal extremities, and amplifies the risk that is not really present in non-xylazine drug samples. Next slide, please. So this can certainly be a presentation in and of itself, but a kind of quick how-to on treating and addressing xylazine wounds. So this purple image that you'll see is actually a guide that is circulated a lot in some of our spaces that we work in, and provides a very kind of easy to understand way of triaging and managing wounds for people who use drugs. So quickly, assessing for skin and soft tissue infection. Given this particular patient's risk of MRSA, we treated with Bactrim and had close follow-up with on-site PCP, which was me. Keeping wounds clean is of primary importance. Washing with something as simple as soap and water. In our site, we have the ability to use chlorhexidine scrub sponges that you might find in the OR and sterile saline. So we were able to do at least biweekly or twice a week chlorhexidine and sterile saline cleanses together while she used soap and water on her own. Keeping wounds moist, but not wet. So very simple principles are if they're wet, make them less wet, and if they're dry, make them less dry. And utilizing something like A&D ointment, which many of us have directly accessible to us, in order to keep the wound edges supple and able to heal. And then keeping wounds covered, primarily by using non-adhesive dressing, something called Telfa, which does not adhere to the wound and does not cause further tissue damage when it's removed. Using roll gauze and Coban or ACE wraps where it's appropriate. And by appropriate, I mean when you are able to see a patient frequently or you believe that the patient is able to remove those dressings with frequency once daily in order to prevent any vascular compromise. And then changing the dressings every day. Next slide, please. So this is our patient's wound progress. So I first met her at the end of July. So the image that you see in September is actually, it's about a month's worth of 2 times a week wound care. And as you can see, by following very basic principles of wound care and very regular wound care, we were able ultimately by this month to have the wounds completely be healed. And a lot of this came from very, very intentional efforts on the patient's part to maintain her relationship and care and to also acknowledge, so to take on a lot of the ownership of her care by being able to do this on her own as well. Next slide, please. So very kind of some practical tools that folks can use and can offer patients in terms of how to keep themselves safe from some of these sequelae are xylazine test strips. So this is something that we use a lot here in New York City. I'm currently sitting next to a drawer full of them, and I gave at least 5 out today, this morning. So checking your sample using xylazine test strips. This is a very simple way of detecting some amount of xylazine within a supply of any sort of drug. It can be a pill, it can be a powder, and essentially what this comes down to is mixing a very small amount of the drug with about a penny-sized drop of water, placing the end of the strip into it and letting it sit, and essentially following the directions. If both the T and the C are red, it is negative. If only the C is there, it's positive. And if the T is there, it's invalid. So it's a bit non-intuitive, unintuitive, but just reviewing this with patients and reviewing it with yourself until it feels comfortable is a great way to allow people to at least know what is in the sample that they're using. Next slide, please. And relatedly is how to counsel patients. And so these are tools that everybody has access to, even without xylazine test strips. So one is using with friends who have Narcan or having Narcan on you. And Narcan is an opioid overdose reversal agent, which can be most frequently nowadays is intranasal, but there are also intramuscular formulations as well. And using with friends who are ready to administer rescue breathing. So one of the pieces that we talked about before was the enhanced risk of respiratory depression through CNS suppression. And so being able to acknowledge that despite the administration of Narcan, this xylazine-related overdoses may also necessarily involve rescue breathing in higher frequency. Calling the Never Use Alone hotline. So this is a hotline that anybody can use. This can be provided to patients and they can call this number. And essentially it is supposed to kind of create the equivalence of having someone around you who can respond to an overdose or at least respond with emergency with an emergency response if they're not able to make contact with you on the other side of the phone. And importantly is starting low and going slow. So even if your sample is found to have xylazine in it after you use test strips and a patient is still intent on using it, starting low with a very, very small amount and going slow until reaching the desired effect to maximize the intent of their use and minimize the harms of their use. Again, using test strips for xylazine and fentanyl, which are available as well. And then just very simply, because it can cause this deep sedation for 4 to 8 hours, using it in a place where you feel safe. Securely storing your belongings, being in a comfortable seated position, and trying not to rest on your arms or your legs or crossing your arms or your legs in a position that could cause vascular compromise. And for patients who are interested, always having the conversation about medications for opioid use disorder, including buprenorphine, methadone, and in cases where it's appropriate, naltrexone. Next slide, please. And so this is actually just came down from a patient's apartment, and this is the bag that I bring with me. So the bag's on the left and the contents are on the right. I always have Narcan. I always have clean syringes. I always have fentanyl and xylazine test strips and a small sharps container that patients can use. Sometimes the sharps container is used for Ozempic needles, and sometimes it's used for other types of needles. And so it can be very functional in a lot of ways. So next slide, please. That's it. Thank you.
All right, so as we conclude, I hope we have been able to describe practical ways of supporting patients experiencing homelessness, recognizing that experiencing homelessness makes it harder to control chronic conditions and easier to develop new conditions. When caring for patients, it can be helpful to explore where a patient is staying, what their concerns are, and what their goals are. And clinical encounters can provide important opportunities to offer social interventions that can impact health and wellness. And so the next couple of slides have our resources, our references. And I will stop share and see if there are any questions or reflections.
I have a question, just for curiosities. Um, with the homelessness, like, and the refugees being in NYC, has that like affected you guys?
Yeah, so that's a really wonderful question. So I didn't talk too much about New York City specifically, but New York City has a very highly structured set of services for people experiencing homelessness. And we have in New York City what's called the right to shelter. And that is a, you know, 4-decade-old mandate that the city is required to provide shelter for anyone who is demonstrating homelessness. And so with the influx of migrants over this past year and a half or so, which has been a larger influx of at this point, over 100,000 people who are new arrivals to New York City, who are, primarily folks who are seeking asylum. It's when we say has it affected homelessness, around 50 to 60,000 individuals who are seeking asylum, who are new arrivals to New York City, are residing in the shelter system. And so from our city perspective, it's been a big jump in the number of people who are eligible for shelter, and there have been kind of different responses for folks who are new arrivals compared to folks who were previously residing in New York City. And so it's actually, this big jump has contributed to different measures by the city, including threats to our right to shelter in New York City, which impacts not just the folks who are the new arrivals seeking asylum, but also all of our neighbors experiencing homelessness in New York City, where we might lose that right to shelter for everyone, which is very, from a healthcare perspective, as I described, where someone is experiencing homelessness dramatically impacts their morbidity and mortality. And so it's affected things kind of like more immediately, but also could impact things kind of longer term from the city's responses. Andreas, I don't know if you have any other additional thoughts.
No, I think, it's interesting. I mean, just from a personal practice perspective, working within a supportive housing facility where, folks are housed, insurance and documentation status are, prerequisites to be able to have this housing. It's very interesting to work in this space while the kind of landscape of homelessness is also changing across New York City, and kind of being kind of nestled firmly within it, but also not having on a day-to-day basis to contend with some of those questions as they're coming up, and kind of on a policy level, they're becoming extremely relevant. So not that that's an answer to your question, but I think it's just to say that even within the work of homeless healthcare, there are certainly different levels of interaction with some of the various levels of engagement you could have, if that makes sense. And so, a lot of the work that also seems to be happening is very kind of grassroots focused, self-organized work in terms of supporting some of the folks who are living outside, who are arriving to the city, in addition to kind of what the city is able to provide. And policies are changing rapidly, budgets are changing rapidly within the city, in a direction that does not seem like it will be able to support everything that we're probably walking into, as a city over the next couple months to years.
Right. I just wanted to commend like you guys for even like doing that, because that was going to be like my question. Are you guys facing like budget cuts, like, or are you guys getting more support? But I was just curious on, how's that going in terms of like healthcare for increasingly growing population.
Yeah, so from a, financial standpoint, um, there are in New York City about a dozen FQHCs that also have this special designation as a homeless healthcare provider. And so in addition to typical FQHC subsidized funding, there's additional funding as a 330H program. And so again, there's like these wonderful structures that help to support individuals. But then when we think about how losing that right to shelter means more people are going to be unsheltered, then everything becomes more complex. And so will we be able to appropriately address the needs of our patients, or are things going to be more advanced when we see them and actually end up requiring, more intervention than if someone was in shelter or housed, of course.
I have a question. So, like a lot of times, like, so we're in the hospital and we take care of like our, say, like podiatry patients is probably, and in our clinic, like we do have quite a bit of patients who are homeless or, in any spectrum of that, and probably not going to have good follow-up care. What would you say are a few of like the kind of safest go-to like diabetes and hypertension medicines? I know y'all kind of touched on that. If like they may not get follow-up and won't be able to check.
Yeah, so I would say really individualizing this care. So sometimes what that means for me and how I describe it to the learners, medical students, residents, fellows who I have with me is that this is VIP care. This is concierge medicine. We have to figure out what makes sense for our patient and then, lay out what the possibilities are and offering, what makes sense to your patient. And so asking those questions of, where are you staying? Do you have ability to store your medications? Does it make sense for us to prescribe a shorter course of medication? So if it is damaged or lost or stolen, that you'll be able to get medications again more quickly than having to, face insurance challenges or pharmacy challenges of getting another prescription sooner. And then is it possible to come back to clinic to a provider, or does it make sense to identify those options that don't require as close monitoring, that then you can, set up kind of an action plan for patients that again makes sense for their lives. Andreas, any additional thoughts?
I was going to say this is perfect because we are writing a paper about what to do for your patients who are in the hospital and maybe leaving the hospital before you think they're ready to, and kind of what are some ways to maximize the impact of that and reduce some of the harms. But yeah, I agree completely with what Dr. Kumar is saying, which is, both in clinic and in the hospital, this is completely patient driven, right? And I think that that's, from my perspective, how all care should be, but I think something that we have, take a special, pay special attention to in terms of what is it, what are your limitations, what are your parameters, what are my recommendations, and how do those two things meet? And the plan is, offer the best care while also respecting the limitations that you have for a variety of reasons, right? And being kind of strapping and being to say that this is not just, hopefully not just from it, but it's hopefully a lot of visits. We'll to kind of chip away at some of these things, and whatever that might be. And so it's individualized, very much over time, which I'm sure you all are no strangers to as family medicine residents. And just certainly know no one size fits all.
Yeah, thank you.
I will say another really valuable resource is the National Healthcare for the Homeless Council. They have a wonderful set of trainings and also kind of modified clinical guidelines to help kind of, when you're engaging with a patient who's experiencing homelessness, like what questions to ask, what are some of the ways to modify care to meet the needs of a patient. So you aren't having to like think creatively kind of every single time kind of on your own. So I'll put that in the chat also.
Can I ask a quick question? This is more of a asking y'all to share your educational programs you have in your residence and your fellowship. What is it like?
Yeah,
Thank you.
absolutely. Yeah, absolutely. So we have kind of a range of training depending on kind of stage of training. And I will say that if anyone's coming to STFM, we're also doing a session kind of going over what that looks like kind of across the training spectrum from like pre-health to medical student to, resident to fellow. As far as our resident experience for rotations, we really think of it as an opportunity to have exposure to what healthcare can look like or healthcare delivery can look like for, in these under-resourced settings in a resource-rich community. And it's really just exposure, but we're also focusing a lot on the educational aspect around the, historical and sociopolitical aspects that have led us to have in New York City 100,000 people experiencing homelessness, and also thinking about the medical conditions that we see in higher rates among people experiencing homelessness. Because, again, the exposure to the shelter-based clinics and the mobile units, but again, we're all already caring for people experiencing homelessness in our FQHCs and in our hospital, in our ED, and it's about thinking critically about how to provide the best care. And then for our longitudinal curriculum, we start off with that 2-week rotation, and then, every, about 1 to 2 sessions a month, the residents will come out to the shelter-based clinics or mobile units or street outreach, and then also do scholarly work and come to, the National Healthcare for the Homeless Council conference and attend homeless healthcare rounds, which includes, joining our fellowship didactics. For our fellowship, we've had 1 to 3 fellows per year, and the didactics around or our training around at the fellow level really focuses on gaining a lot more competencies in wound care, gender affirming care, HIV and hepatitis C, substance use disorders, including alcohol and opioid use disorder, talking a lot about trauma and mental health and trauma-informed care. And then also, again, how do we provide realistic care that's also feasible and safe for our patients when addressing chronic conditions and preventive health. And so, our fellows spend about 1,000 hours providing clinical care over the course of the academic year in homeless healthcare spaces. They receive about 200 hours of clinical training through weekly didactics and, in those kind of core areas that I mentioned. They also spend time in kind of high yield areas, including spending time with clinicians in, harm reduction and addiction medicine and, virology. And they also spend time with, at a policy level, spending time with the Department of Homeless Services and the Office of the Medical Director. So there's a lot of, a couple of different layers of what training looks like for our fellows, which is, the direct patient care, the didactics, and then also community-based engagement and learning about, what the services are in our community, who else is thinking about our patients, and how can we recruit them kind of in real time to support our shared patients. So that was a really quick kind of review. I see in the chat a request to share a copy of the slides. I've shared it with Kelsey, and so welcome to pass it along. And very happy if questions come up to get connected and talk further about any of these. And I'll also pass along a flyer for our Homeless Healthcare Fellowship for any trainees who might be interested.
Thank you. Thank you both. That was great.
Well, thank you all so much.
Thank you for having us.